Hello everyone, my name is Kelly Oldziej, the PGY2 Emergency Medicine Pharmacy Resident at Yale New Haven Hospital. Thank you for taking time out of your day to join me in reviewing the EvK trial, Etomidate versus Ketamine for emergency endotracheal intubation. I'm excited to share this with you all as the topic of RSI is one I found fascinating as an EM pharmacy resident. It's been a great conversation piece and educational opportunity amongst myself and my EM colleagues, including both pharmacists and physicians. Regarding disclosures, I have no financial disclosures or conflicts of interest related to the content of this presentation. To start us off with a brief background, emergency endotracheal intubation is typically performed using rapid sequence intubation, or RSI, which entails the quick and appropriate administration of a sedative agent followed by a paralytic agent. The major goal of RSI is to create an environment where the trachea can be intubated quickly with as little difficulty as possible. I wanted to point out a few major considerations regarding RSI and the choice of induction agents, specifically etomidate and ketamine, which are often used to sedate critically ill patients undergoing emergency endotracheal intubation. Both agents have similar profiles regarding a rapid onset of action and hemodynamic stability compared to other induction agents, such as propofol. Historically, etomidate is our workhorse and standard of care as it's commonly used across the country in emergency departments. Conversely, interest and usage of ketamine have grown with more data supporting its use in RSI, as it touts an advantage with both a sedative and analgesic effect. However, their associated side effects have been the subject of controversy in RSI, as there's conflicting evidence regarding specific induction agent use and patients at high risk for peri-intubation complications. The answer to which agent produces a more favorable outcome in patients remains uncertain at this time. Shifting gears, we'll take a closer look at the associated controversies with both etomidate and ketamine in emergency endotracheal intubation. Etomidate decreases the production and secretion of cortisol from the adrenal gland through direct inhibition of the 11-beta hydroxylase enzyme, which is known to cause transient adrenal suppression. Controversy exists whether a single dose of etomidate and its related adrenal insufficiency will lead to poor outcomes. Ketamine, as we saw illustrated in the previous slide, does have indirect sympathomimetic effects due to the inhibition of endogenous catecholamine reuptake, which is seen as favorable in those who are hemodynamically unstable. However, ketamine may cause myocardial depression, leading to decreased ventricular contractility and more frequent hypotension in critically ill patients. Ultimately, the clinical significance of etomidate's adrenal insufficiency and ketamine causing myocardial depression remain unknown. We will begin to review existing literature evaluating etomidate, ketamine, and their patient-related outcomes in RSI. To provide background, the Corticus trial is a multi-center randomized placebo-controlled double-blind study evaluating low-dose hydrocortisone in septic shock. This a priori study listed here of the Corticus trial sought to determine the effects of etomidate and its associated adrenal suppression. Specifically, the question asked was, does a bolus dose of etomidate increase non-responsiveness to corticotropin and the rate of mortality in patients with septic shock? We can see the authors found 96 patients who received etomidate 72 hours prior to trial randomization in the Corticus trial. They found a significantly higher amount of patients with a lack of corticotropin response, particularly those who received etomidate, as well with an increased all-cause mortality at 20 days associated with etomidate administration. Interestingly, though, hydrocortisone did not affect the rate of mortality. There are various critiques with this trial. The authors failed to adjust for multiple hypothesis testing, keeping in mind as well etomidate may have been chosen for more critically ill patients, and it is postulated that the ACTH effect of etomidate occurs within 48 hours, but change in survival curve within this trial is not seen until 10 days after administration. Ultimately, my takeaway, it seems concerning that in the whole Corticus population, increased mortality could not be demonstrated in the sepsis-related adrenal insufficiency group, but lately in this subgroup analysis, etomidate-related adrenal insufficiency was found to be associated with increased mortality. The reasons for these contradictory findings need to be further explored. Moving on, the Ketamine trial is the most robust data we have to date regarding etomidate versus ketamine in RSI. In this prospective randomized controlled trial, the authors compared differences in morbidity between critically ill patients who received an induction dose of either etomidate or ketamine for endotracheal intubation. Upon undergoing 1-to-1 randomization, the primary outcome was the maximum SOFA score during the first 3 days of the ICU length of stay. No significant difference was seen in organ failure scores between etomidate versus ketamine during this time. As you could expect, basal cortisol levels were lower with a higher proportion of adrenal insufficiency reported in the etomidate group, specifically 86% versus 48%. Ultimately, this trial proved ketamine can be considered a safe alternative to etomidate in critically ill patients. However, no difference in mortality between responders and non-responders of the ACTH test was seen, indicating that adrenal suppression did not influence outcomes. The two observational cohort studies listed here provide a real-world look and evaluation of etomidate and ketamine for RSI, utilizing the National Emergency Airway Registry, otherwise known as NEAR, which is a prospective ED-based airway registry of consecutive ED intubations in a network of 25 academic hospitals. On your left, Moore and colleagues utilized descriptive methods to determine the rate of use and adverse events between etomidate and ketamine in patients with sepsis. Their primary outcome was the choice of RSI induction agent for intubations with concern for sepsis. Comparing these sepsis versus non-sepsis cases, while etomidate was more commonly utilized across the board, ketamine was administered more often in patients who had a concern for sepsis. How many times can I say sepsis? Interestingly, regarding adverse effects, ketamine caused more post-procedural hypotension in the septic cases, 74% versus 50% with etomidate. Conversely, on your right, April and colleagues compared patient outcomes in normotensive patients undergoing RSI. The rate of peri-intubation hypotension was decreased in the ketamine group versus the etomidate group, with a larger percentage of patients requiring treatment for peri-intubation hypotension. The study defined hypotension as a systolic blood pressure of less than 100 millimeters of mercury within 15 minutes after the induction agent was administered. Overall, the data suggests that intubating providers should reconsider the premise that ketamine offers superior post-intubation hemodynamic stability as a reason to choose ketamine over etomidate. Keeping all that in mind, this leads us to our review and critique of the EvK trial, which was conducted at UT Southwestern Medical Center. The authors conducted a prospective randomized parallel assignment open-label single-center trial occurring from June 2016 to September 2020. They sought to determine if a survival benefit exists in critically ill patients who received either etomidate or ketamine for sedation during emergency endotracheal intubation. Notably, emergency endotracheal intubation was performed by an anesthesia-dedicated airway team, which operates separately from the clinical critical care teams. The airway team could adjust doses of medications based on clinical judgment if deemed appropriate. As you can see, we have the dosing ranges provided by the study here, but the airway team did have full disclosure to adjust those doses if necessary. The clinical care teams, as the open label trial suggests, were not masked or blinded to the exposure drug. Additionally, as well, the paralytic agent was chosen by the airway team, and this process was not standardized within the trial. Patients were included if they were at least 18 years of age and requiring emergency endotracheal intubation. Very limited inclusion criteria here. Patients were excluded if they were pregnant, if they required endotracheal intubation without sedative medication, such as those in cardiac arrest, those who were neurologically obtunded, or those undergoing awake intubation. Patients were also excluded if they had a known allergy to etomidate or ketamine. Thank goodness. The airway team was also allowed to screen out patients if they felt a particular agent was indicated for an eligible patient, even if exclusion criteria was not met. Similarly to the choice of paralytic agent, this selection process was not provided within the methodology of the trial. There were a number of outcomes evaluated in this study. The primary outcome was designated as the proportion survived on study day 7, with the proportion survived on study day 28 being a secondary outcome, in addition to the duration of mechanical ventilation, ICU length of stay, any requirement of vasopressor therapy. However, as an EM pharmacist, I thought it's interesting that they excluded the use of vasopressor or inotrope therapy within the peri-intubation period. As well, to no surprise, they also evaluated the assessment of a new adrenal insufficiency diagnosis related to the use of etomidate. Taking a look at their statistical analyses, the authors determined an 80% power and 0.05 level of significance were needed to identify a 10% difference in proportion survived at 7 days post-intubation. This required a patient population size of 750. Regarding the statistical tests utilized for their primary as well as secondary outcomes, these were appropriate for their data set. Now I'm coming at you here with a large number of baseline characteristics. End all be all, comparing etomidate versus ketamine, both groups were well balanced. The chronic health score was used in the original Apache article and is now used to describe baseline health status of patients, which designates ultimately that a chronic disease may impair patients' activity at baseline. So category B, meaning mild to moderate limitation of activity because of chronic medical problem, with C being serious but not incapacitating limitations of activity. The majority of patients were intubated for shock or acute respiratory failure with similar vital signs prior to intubation. Diagnosis of sepsis pre-randomization was about 34% in both arms, with sepsis pre or post-randomization being upwards of 50%. Finally, we've arrived at the results section. Evaluating their primary and secondary outcomes, the authors found day 7 survival rate for ketamine was higher than etomidate, specifically 85% versus 77%. In other words, patients in the etomidate arm were 1.6 times more likely to die compared to ketamine. However, at day 28, survival rates for both ketamine and etomidate were not significantly different. Interesting. The duration of mechanical ventilation, ICU length of stay, and percentage of vasopressor use were not significantly different between either group. And lastly, as previously illustrated in the background literature I presented, ketamine was associated with more frequent administration of post-induction rescue therapy with vasopressors and had a greater incidence of post-induction cardiovascular collapse when compared to etomidate. I myself am more of a visual learner, so I wanted to provide the Kaplan-Meier survival curve depicting day 7 and day 28 during study evaluation. With ketamine designated as the red trend line and etomidate as the blue, you can see the statistical difference in survival at day 7, but ultimately this trend dissipates and does not maintain significance by day 28. Personally, as a pharmacist, I love to evaluate exploratory outcomes. I tend to nerd out here as I can take a look at the average drug doses utilized for our induction agents. Interestingly, etomidate on the lower end of the range at 0.2, where it can go upwards to 0.6. The predominant neuromuscular blocking agent utilized in this study population was rocuronium, which differs from our standard of practice at my current institution. We as well get the post-induction vitals, including blood pressure, heart rate, the incidence of post-induction vasopressor bolus, as well as cardiovascular collapse. Similarly to what we discussed earlier in the near cohort study findings, the use of post-induction vasopressor therapy is consistent with those studies as well regarding increased usage within the ketamine arm specifically, as well as you can see the increased rate of post-induction cardiovascular collapse with ketamine compared to etomidate. For background, the authors utilized the Vanderbilt definition to define post-induction cardiovascular collapse, which is either new post-induction systolic blood pressure of 65 or less, and or immediate need for IV vasopressor bolus or dose escalation, and or cardiac arrest or death within 1 hour. Feel free to spend some extra time here for yourself as well. As we've seen, the authors assessed a great amount of data within this trial, but ultimately concluded while the primary outcome of day 7 survival was greater in patients randomized to ketamine, there was no significant difference in survival by day 28. Heading into my own personal critique of this trial, while this does seem concerning for ketamine to tout such a great survival advantage over etomidate, it's important to consider mortality at 28 days in the ICU setting can be attributed to multiple confounders and multiple changes in the patient's clinical course that this trial likely couldn't account for. My own personal critique includes various strengths and limitations. Starting with the strengths, the randomized trial design was appropriately distributed, increasing internal validity of the study, so check for great randomization. The study was, in addition, adequately powered, which, as we know, adequate power equals a lower risk of type 2 error. The induction doses were consistent with the suggested trial protocol. I mentioned previously that the airway team did have free reign and availability to cherry pick which person got which induction agent as well as the dose, but end all be all, we were maintaining consistency with the suggested protocol. I do personally favor hypothesis generating results as well. We discussed in the previous literature background portion of this presentation the higher instances of hemodynamic instability requiring treatment, as well as cardiovascular collapse associated with ketamine, which was elucidated here today as well. Limitations include the potential for selection bias. This is attributed to patients not being enrolled consecutively, as well as the clinical care teams being unblinded. The airway team itself as well is highly specialized, which can limit external validity. The practice within this trial produced a 91% first pass success rate, which was great, and that likely contributed to the standardized care in each group. However, this practice may not be generalizable to other centers who do not use such standardized protocols. I did find the endpoint measure of 7-day mortality to be a limitation. A one-time induction dose alone is difficult to incriminate as the sole intervention leading to mortality. We know etomidate's transient adrenal insufficiency lasts upwards of 48 hours. We've seen ketamine hemodynamic instability and cardiovascular collapse following administration. So 7 days for me seems to be a bit prolonged. Also, a more patient-oriented outcome could have been evaluated, such as survival with favorable neurologic outcomes, as opposed to just the proportion survived at day 7. While I wished for a more interactive and dynamic approach to provide the EvK trial article critique throughout the American Thoracic Society, it was a sincere pleasure. Thank you for accompanying me on this journey if you're still here. And while I can't know your feedback, comments, takeaways in real time, I'll end by providing you some of mine. At this point, based on the data and limitations noted within the methodology, I think it's interesting that ketamine was seen to have a 7-day mortality benefit compared to etomidate, despite having more post-intubation vasopressor requirements, cardiovascular collapse, and CPR initiated. I think this could be chalked up to the fact that the airway team was so aggressive about post-intubation management that they were able to overcome these complications. Some food for thought for you. While ketamine may have better short-term outcomes than etomidate, it may not make a patient-oriented difference in the most critically ill of patients. Ultimately, keeping this in mind, how I continue to practice when we're undergoing RSI for a specific patient is making a patient-specific decision on which induction agent to utilize. And I think this trial was a great review in regards to various different considerations that you could hold in the back of your pocket when you're evaluating whether you should choose etomidate versus ketamine for a patient requiring emergency endotracheal intubation. Again, thank you so much for this opportunity to present a journal article critique to the American Thoracic Society. As an emergency medicine pharmacy resident, it's an esteemed honor to bring part of my practice and share it with you all on a national level. Again, my name is Kelly Oldziej, the PGY2 EM pharmacy resident at Yale New Haven Hospital. I've included my email, kelly.oj. It's not spelled how it's pronounced, at ynhh.org. I would love to make this as interactive as possible if you have any leftover questions, comments, feedback. I hope this was of some benefit to your practice. Maybe ask some more questions, think a little bit more about induction agents and RSI. It's a topic I'm super passionate about.